pleasure to be able to give you some of our thoughts and some of the work that's ongoing, not just in our group, but of course across the whole spectrum of pharmaceutical drug development as it relates to FTLD. I'll preface my talk by noting that in many ways, neurodegenerative drug discovery is probably one of the last frontiers in drug discovery, in that, as many of you know, there really are no drugs currently available for any of the neurodegenerative conditions that really slow or stop disease progression. And so it's a very challenging field from a drug discovery perspective, but you know, we're working hard to try to come up with approaches and therapies, and I'll touch on some of these. So in my talk today, I'll break it down into maybe three separate sections. First of all, I'll just give an overview of what's ongoing now in the clinic with regard to FTLD. Again, we're kind of in early days in drug discovery for FTLD and related neurodegenerative disorders, and so there's not a whole lot in the clinic yet, but there's a little bit ongoing. And then I'll switch over and talk a little bit more about the efforts that we have ongoing at the Center for Neurodegenerative Disease Research here at Penn, which henceforth I'll call CNDR. And both focused on FTLD, of course, but of course, as you've heard from some of the talks already this morning, there's often overlap in these disease categories. And so, you know, for example, in FTLD, where there's often Tau Pathology, that also a drug that's affecting Tau may also have applicability for Alzheimer's disease, where you also find Tau Pathology. And so I'll talk about our general drug discovery program and why we are even attempting to do drug discovery in an academic setting, and then focus more specifically on our FTLD AD drug discovery programs. And then, of course, we'll have a breakout session afterward, I guess, where we'll be happy to have questions. So you've heard a lot already this morning, and a very nice talk by Viviana about kind of the breakdown of the genetics of FTLD. And the two major pathological features you'll see in the brains of individuals with FTLD. There's roughly 50%, as Viviana showed, that have Tau pathology associated with their FTLD, and of course, these are typically Pick's disease, progressive supranuclear palsy, and cortical basal degeneration patients. And then you have also now the more recent pathology that's been identified, the TDP-43 that you've heard a lot about this morning as well. And of course, there's different subtypes of FTLD within the TDP-43 class as well. But these two pathologies make up the vast predominance of what is seen in the brains of the FTLD patients. And as you saw in slides from other speakers, you get this misfolding, for reasons that we don't totally understand, where you deposit and get aggregates of these two different proteins in the brain. Now, I'll say right now that the discovery of TDP-43, which occurred over the last several years, and continue to learn more about this protein, is sufficiently early that we really don't have good druggable approaches yet to try to impact on kind of this half of the FTLD spectrum. And so what I'm going to focus on, and what the industry is focusing on right now with regard to FTLD, is more of the Tau-based FTLD patients. Okay? Now, this is just a little diagram to talk about Tau. You know, you've heard that Tau forms these inclusions in the brains of those with FTLD as well as those with Alzheimer's disease. These inclusions form within the cells known as the neurons, or the nerve cells, that of course play the very important role in learning and memory, etc. But Tau, you know, has a normal function when it's not sitting, unfortunately, in these aggregates in the disease state. And the normal function of Tau is it binds to a structure within cells known as microtubules, okay? And you can think of microtubules essentially as like railroad tracks within a cell. And in nerve cells, these are particularly important structures, these microtubules, because nerve cells are kind of long cells. They have these long projections, and then they make connections to another nerve cell that allows the nerve impulses that ultimately form memory and learning and even motor function as well. And so these railroad tracks are very important in these long cells because they allow cellular materials to be shuttled up and down the railroad track. Just imagine, this is a railroad track in a cell, and you've got railroad cars delivering things to the end of the cell and bringing things back up to the center of the cell where the nucleus is. And so Tau plays a very important role in stabilizing these microtubules. And so in a disease state, such as the FTLD patients who have Tau deposits in their brain, the Tau, for reasons that we don't fully understand, but are gaining a greater understanding, comes off these microtubules, okay, and forms these aggregates within the cells that we've discussed, these neurofibrillary tangles that you'll see within the cells of these patients. Now, these structures in and of themselves may be toxic or may be bad and may have a detrimental effect on the cells. But it's also quite possible that the fact that you're no longer stabilizing these railroad tracks in the cells, that they start to fall apart, could also have negative consequences, right? You're not delivering the goods anymore to the cell. And so the approaches that the pharmaceutical industry and our group are looking at when it comes to the tau diseases, or tauopathies as I'll call them, are twofold. One, trying to investigate whether these types of structures, these misfolded aggregates, cause disease. And then, in addition, trying to determine whether this loss of function of tau, so in other words, where it's no longer doing its normal job, where the microtubules now fall apart, whether that's having a negative impact as well, okay? So, given this kind of understanding of what tau does and the possibility that these misfolded aggregates, these neurofibrillary tangles, are detrimental to the cells, has led to a couple different approaches by the pharmaceutical industry. One of the things you'll see in these neurofibrillary tangles is that the tau protein that's in there is what we call hyperphosphorylated. So phosphate is just a tag that's put onto the tau itself. And that has some consequences. We know that when tau gets hyperphosphorylated, it doesn't bind the microtubules as well, okay? And that may, in fact, be the first thing that starts this whole downward spiral. Tau gets phosphorylated, comes off the microtubules, and then it aggregates. And so some companies are trying to block this hyperphosphorylation, okay? And this is done by what are known as enzymes. These are proteins that you may have heard of, enzymes that do a lot of things in the body, but there are certain enzymes that put on these phosphate groups. And those are called kinases. And so there are programs within the pharmaceutical sector to try to block the kinases, those enzymes that put the phosphate groups onto the tau protein. And at the moment, well, one of the key kinases is known as GSK3, okay? And there's currently a drug in clinical trials and phase 2 testing in progressive supranuclear palsy patients, as well as Alzheimer's patients, that are trying to block this hyperphosphorylation of tau, to try to keep it from falling off the microtubules and forming these aggregates. And so we'll see how that does. This is a relatively small company. I think it's a Spanish biotech company, and so we'll see if they have any success. But there are also, I know, multiple pharmaceutical companies that are also working on this approach, just not quite as progressed as this particular program. There's also in clinical trials right now a drug known as davunitide that is trying to essentially deal with this loss of microtubule stability, the railroad tracks falling apart. And so this peptide that they've found with this name is again in phase 2 testing in PSP patients. And again, this is a biotechnology company with the name of Elan, okay? And then finally, there are a number of ongoing research programs within the pharmaceutical programs within big companies that are trying to attack this issue of tau misfolding and tau aggregate formation, but they're at an earlier stage, preclinical stage. And again, probably the major approach that's being looked at is inhibiting these enzymes, these kinases that put on the phosphate on tau that seem to precipitate this loss of function and ultimately into the neurofibrillary tangle formation. A more recent approach that's being considered, and also being considered, for example, in our group, is an immunotherapy approach where you treat with an antibody. An antibody is something that will recognize a specific protein. And so the thought is if you have an antibody administration with an antibody that recognizes tau, if we can get that into the brain, it might actually bind up some of the misfolded tau, because one of the more recent hypotheses that's being supported by very encouraging data is that as Tau pathology spreads through the brain, and there clearly is a spread with time as patients get sicker and sicker, that there's release of misfolded tau that goes from one cell to the next and it propagates this whole misfolding. And so if we could essentially bind up that misfolded tau with these antibodies, you might also have an impact. And so this is something that I think you might hear more of in the upcoming years. Before I move on to our program, the other thing to note is there are also clinical trials that are just geared towards treating the symptoms of FTLD. And so there's a drug that's been approved for Alzheimer's disease known as memantine that binds a class of receptors in the brain known as glutamate receptors that play a very important role in learning and memory, but when overstimulated can actually be neurotoxic, can kill neurons. This drug was approved for Alzheimer's, where it's believed that there might be some of this overstimulation and neurotoxicity, and they're now testing this also in FTLD patients to see if it can slow the rate of behavioral decline. And then there's also a Parkinson's disease drug known as Tau Pathology that in Parkinson's boosts dopamine levels, which is one of the major problems with the Parkinson's disease brain, is you lose your dopamine-producing neurons. And so this drug is approved for Parkinson's, but they're now testing this also in FTLD patients to see if it'll improve symptoms. But again, these will not slow disease progression per se, they're really just symptomatic treatments. Okay, so that's kind of where the field stands right now, I think, with regard to FTLD drug discovery and clinical trials. But what about, ongoing efforts, in particular in our group? And so that's what I'd like to talk about next. But before doing so, I want to just talk about our center, or a little bit, our drug discovery center within CNDR, because I often get asked the questions, why would an academic group do drug discovery? Isn't this what pharmaceutical companies do? It certainly is what pharmaceutical companies do. It's certainly what they have done in the past. But for any of you that have kind of kept track of this area of the pharmaceutical companies, they've had some pretty rough times recently. They've had a lot of patents expire such that they're not making the profits they used to make. They're not coming out with new drugs as frequently as they used to for multiple reasons we could discuss. But the net consequence is that their bottom line is hurting, which has resulted in a lot of layoffs, over 100,000 people in the pharmaceutical sector losing their jobs over the last 3 or 4 years. That has really impacted on future drug discovery, I think, okay? In particular, early stage research in the pharmaceutical companies that lead to new drug discovery opportunities, the R phase, the research phase, or the research and development you often hear of in pharmaceutical companies. They still do the D phase, the development phase, running clinical trials, manufacturing drugs, et cetera, quite well, but they're not doing the R as well anymore because of some of these drastic cuts in their personnel. And this is particularly true, unfortunately, in the area of neuroscience. Certain pharmaceutical companies are just essentially getting out of the neuroscience area in general because they think it's just too difficult and too hard to make drugs. Unfortunately, AstraZeneca, for example, just last week announced that they're essentially exiting from the neuroscience areas. And so what does this mean? Well, it means someone's got to develop the new drugs, hopefully, to treat neurodegenerative disease. And I think there's a role for academic groups to do this early stage drug discovery, complementing the efforts of industry. And in fact, reality is industry is increasingly looking to academic drug discovery centers, I think, for early stage opportunities to help kind of bring new early drug candidates further along in the process. And in fact, we don't try to compete with pharmaceutical companies. That would be suicidal, but we do try to complement their efforts. And the way we do that is, one, work in difficult therapeutic areas in which they are kind of loath to invest. And again, a prime example being neurodegenerative disease. In part, the reason that they stay away or are a little bit scared of areas like this is that they're difficult. Developing drugs to the brain is a very difficult thing, but it also requires a lot of disease-specific expertise. And again, if they're laying off a lot of their good researchers, they don't have that disease-specific expertise anymore, and so they need to find that in academic centers or perhaps biotech companies. We can work on novel or less validated drug targets. As the pharmaceutical sector becomes more restrained and under financial pressure, they also become more conservative. And so they don't want to work on approaches that really don't have a high level of validation. And so we can provide, through our efforts, some validation to an approach that then might spur industry investment down the road. And of course, we can work on orphan diseases. Unfortunately, of course, pharmaceutical companies are driven ultimately by the bottom line. The bigger the market, the more interested they are. Alzheimer's disease is the market many who are still in the neuroscience area are looking at, because there's 5 million Alzheimer's patients, but when you get to something like FTLD, it's an orphan disease, there's less motivation from a financial perspective for them. And so, again, academic settings don't have to worry about those kind of financial bottom lines. And of course, we can also even look at drugs, that are off patent, that have been used for some other therapeutic approach, and see if they might have utility in neurodegenerative disease. Again, because we don't have to worry about the financial motivations. So we have set up at CNDR what I like to think of as an academic biotech company. So in other words, we're nonprofit. We don't have to worry about the things that the big pharmas do, but we have many of the same capabilities of a biotechnology company. So we have high throughput drug screening. We have this roboticized system that allows us to look at 10,000 compounds a day to see if any of those might have applicability for the neurodegenerative targets that we're looking at. We have dedicated chemistry support with our colleagues in the Department of Chemistry here at Penn. And we, importantly, have some very sophisticated animal models of disease because, again, working in the Center for Neurodegenerative Disease Research, Virginia Lee, John Trojanowski, these are world experts in developing these research tools that can then be applied to drug discovery. And just to show that I think, the idea of working with academics is gaining favor, in 2010, we announced a very large collaboration with AstraZeneca, the pharmaceutical company, to work in Alzheimer's disease. As I just mentioned, unfortunately, they seem to be retracting a little bit from the neurodegenerative areas, but it's not clear if that's going to impact in our program yet. But we also last year announced a partnership with Bristol Myers Squibb to try to develop drugs for neurodegenerative disease, and I can tell you we're in negotiations now, fairly advanced negotiations with a couple of other companies. And so we are, in fact, now starting to work with the pharma companies to try to come up with some therapies. Okay, and so in the last part of my talk, let me talk about an approach we're taking that I think is pretty exciting and has led to the identification of a potential drug candidate that hopefully will move forward. And this gets back to this idea of compensating for tau loss of function. Okay, again, this microtubules that are the train tracks of the cells and trying to keep the train tracks stable so the train doesn't come off the tracks, and so here's just a literal depiction of that, right? But this really is kind of what could happen in a cell if the microtubules become altered in a way that the materials can't run up and down them properly. You're going to have disaster within the cell. And the cells here we're talking about are the neurons in the brain. And so might we find ways of stabilizing these microtubules when in tauopathies, in FTLD, for example, with the tau neurofibrillary tangles, when they quit doing their job, when the tau quits doing its job, can we compensate for it? Can we find a way to stabilize these microtubules? And interestingly, there are known drugs that stabilize microtubules. And in fact, they're used for cancer treatment. So some of you may have heard of Taxol. Okay, that's used for breast cancer treatment. Well, Taxol works in cancer patients by stabilizing microtubules. Now there, what it does is that microtubules not only play a role in neurons, okay, when a cell divides, some of you may have seen pictures of cells dividing, and the chromosomes get pulled apart, so each new cell has a set of chromosomes. Well, when they get pulled apart, they're moving along microtubules, okay? Now those microtubules dissolve as soon as the cell is done dividing, but what Taxol does is it overstabilizes those microtubules so they can't dissolve, and so it essentially kills the rapidly dividing cancer cells, all right, so that they can no longer divide. Now, is it theoretically possible then, we asked, whether a drug like this might work to stabilize the microtubules in the brains of patients with tauopathies, okay? Now, as we thought about this, of course, we were cognizant of the fact that drugs like this have some fairly severe side effects. They work, as in cancer, as I just said, by killing rapidly dividing cells. Well, you have rapidly dividing cells in your body, right? So your immune cells, for example, divide fairly rapidly. And so one of the side effects of drugs like this is immune suppression. It can also cause what's known as peripheral neuropathy because it overstabilizes microtubules in the nerves of your legs and arms, for example. And so, there are some worries about taking this approach. But the thought was, what if we gave perhaps a lower dose, if we could find a drug that got into the brain, that would have an effect. And so that's what we set out to do. But one of the big problems right out of the box is Taxol and all the drugs that are known to stabilize microtubules like Taxol don't get in the brain. In fact, 98% of the drugs in the world don't get in the brain. And so that's a challenge. And so the challenge was, can we find a drug like this that gets in the brain? And the long and short of it, I won't go through all 2 years of research, but whereas Taxol, for example, is shown here when you administer it to a mouse, here's the plasma levels, it's very high when you administer it, they start to taper off with time. Here's the brain levels. You never see anything in the brain with Taxol. That's why it's no good for treating tauopathies. But we found this class of compounds known as the Epothilones, and exemplified here by Epothilone D, we called it CNDR66 at the time the slide was made, that showed remarkably high levels in the brain after administration that persisted for a long time. Okay, and here's the plasma level. So here is a microtubule stabilizing agent that's in the brain. And this compound actually went to phase 2 clinical testing for cancer before it was stopped because of some side effects. Now we ask, would a compound like this that gets into the brain have potential use then for tauopathy? And we have transgenic mice that have been developed at our center that essentially develop the same neurofibrillary tangle-like pathology that you see in the FTLD patients or Alzheimer's patients in the mouse brain. And that's kind of depicted here. So here's a slice of a normal mouse brain where we're using a reagent that recognizes the misfolded tau. So brown is misfolded tau. And you can see how much is in the brains of these transgenic mice, that essentially what these mice have is one of the mutations in their tau that cause FTLD. And so we asked, could we give a drug like this Epothilone D I mentioned, and have a positive effect on these animals, not necessarily even on their pathology, because all we're trying to do now is compensate for tau loss of function, but at least on their microtubule function and maybe their cell function, and maybe their learning and memory, because these animals show memory deficits just like Alzheimer's patients do. And so we set up a study where we took 9-month-old transgenic mice, we call them the PS19 mice, that already have cognitive deficits, kind of dementia behavior, and this tau pathology in their brain, and dosed them for 3 months with this Epothilone D, but importantly at doses of about 1/30th to 1/100th that would have been used in humans for cancer. So trying to keep the doses low to avoid side effects. And then asked, can we see positive effects on things like their microtubule density, on their axons, which is the extension of the neuron where you see the microtubules projecting, and then even on behavior and perhaps even on the pathology. And then importantly also looking at their safety of the drug. And what we found is that it did have a good effect. And so one of the things we find in these animals is that if you look at their axons in the brain, they have what we call dystrophic axons. They're all screwed up. And that's probably because, again, these railroad tracks aren't working well. Material gets clogged up in there because it's not being transported properly, and it clogs everything up. And if you look at a normal animal, you only see, once in a while you'll see those. You see about 2-fold more of those clogged up axons in these transgenic mice. But when we treated them with this drug at this very low dose, they went back to being like a normal mouse. And in fact, when we look at microtubule numbers, right, the railroad tracks themselves, you can actually see these if you look at very high magnification on what's known as electron microscopy. You see a deficit in the numbers of microtubules in these mice compared to normal mice. But again, we treat with the drug, it increases. In fact, it even looks a little better than the normal mouse. Okay. Now, what about the consequences of this? Does this help the animal in any way? And so we actually did this learning and memory test that's commonly done with these types of mice. It's called the Barnes maze. And so what you do is you take a mouse, shown here, and you put them on a platform like this in bright light. And mice hate light. They're nocturnal creatures. And so they look for an escape hole that's dark. And see, there's only one hole that looks like that. And so they have to learn which way to go and which hole to get into as fast as they can. And if you take a wild-type mouse, shown in black here, the first day, he gets it right 70% of the time. But by the 3rd, 4th day, he's got to figure it out. 100% of the time, boom, there he goes into the dark hole. However, if you take our mice that have the tau pathology, they're pretty slow. They hardly get it right at all the first day, and even by day 4 and 5, they're only about the level where these guys start out at day 1. So they're slow learners. They have learning and memory deficits, essentially. But if you look at the ones that were treated with the Epothilone D, particularly the higher dose, they're approaching the performance of the normal mouse. So this was pretty exciting to us, and this is just another measure. This just tells you how long it took them to find the hole, but the same story. Okay. So we were quite excited about that. But again, what we're doing here is we're trying to stabilize these microtubules. We didn't really think we were going to have any impact on the misfolding of tau and its deposition into these neurofibrillary tangles. And so we were really surprised when we started looking at the brains of these mice. So here's a normal mouse. Again, there's no misfolded tau. Misfolded tau here is going to look like brown. And here's the transgenic animals, like I showed you before. They have a lot of these tau inclusions, these neurofibrillary tangle-like structures. And surprisingly to us, the Epothilone-treated animals showed a huge reduction in the amount of this tau pathology, even though we didn't expect to see this. And again, there's multiple ways we measure this, but bottom line is every time we measured it, we saw an improvement. Now, ultimately, what causes the learning and memory deficits and everything in these animals is this axonal dysfunction because the microtubules aren't working well, and ultimately that kills the cells. You get neuron loss. And you can look at neurons, and here's one region of the brain known as the hippocampus, which is very important in kind of learning and memory. And so here's what a hippocampus would look like in a normal mouse, okay? And there's different regions of it. Doesn't really matter what we call it. But if you look at these transgenic mice that have these deficits in learning, that have the screwed up microtubules, they also have a lot of neuron loss. Look how thin this is here, for example, compared to here, okay? And so we asked, geez, we got rid of this pathology. We're helping the microtubules. What's it doing to the neurons? Because at the end of the day, that's the bottom line. And the bottom line is we brought them back up to looking like this in the drug-treated animals. And so we're quite excited about this. And the other thing I should note, and I'm not going to go through all the details here, we saw absolutely no adverse findings. We looked at all the things that would expect to be changed with drugs like this, like blood cell numbers, peripheral nerve function, et cetera. So anyway, we'll close here and just say we're quite excited by the properties of this Epothilone D, or Epo D as we call it. It normalizes axons and the microtubule density within them. as we saw, improved cognitive performance and reduces tau pathology and even neuron loss without any noticeable side effects. And we believe this is so because we're using it again at doses about 1/100th to 1/130th of the cancer treatment levels. So these data suggest that this drug might have therapeutic utility for FTLD and AD. And in fact, the owner of this drug, we went into this blind. We were just surveying, trying to find the best drug we could. It turns out the patent rights to this drug is owned by Bristol Myers Squibb. They had put it on the shelf because, as I said, they'd stopped clinical trials for cancer, but now they pulled it back off the shelf and have done some safety testing at these lower doses. It looks safe, and so their intent, from what I understand in discussions with them, is to now begin phase 2 clinical trials in patients, tauopathy patients. I'm not sure if they decided which patients yet they're going to go into, perhaps TSP, but I'm not sure they've made that decision yet. So I'll stop there, and I think we'll have some questions. But before I stop, let me acknowledge all my coworkers, which is very important because drug discovery is a team effort, a multidisciplinary effort. We have biologists, pharmacologists, importantly chemists, and of course, leaders like Virginia Lee and John Trochanowski. And all these individuals shown in white played key roles in this Epothilone study, particularly Ben Zhang, who's highlighted down here. So thank you.